Welcome to everybody. It's going to be a very exciting session. It's a blended session with the audience on site and from the distance. We are going to talk about the 3D stents. I'm Giulio Guagliumi from Milan. Here you have my full disclosure. In this session, we have 3 learning objectives. First, to review the clinical role of stent under expansion. We are meeting frequently. To discover an innovative, easy-to-use and non-invasive 3D stents reconstruction. To assess stents during PCI. To see and discuss with you how 3D stents works in different real-world stent scenarios. Here the team that you have in front with presenters, Carlos Collet and Hakim Benamar, and incredible panelists like Nieves and Salvatore and Dejan and the chat master. Without any hesitation, I wanted to go immediately to the first speaker that is going to give you an overview of the concept of a stent under expansion, how frequently we are meeting, and how we are just judging. Nieves.
These are my disclosures. So let's start with the patient. This is a patient that came to our hospital with an inferior STEMI. You can see there the occluded right coronary artery. So as usual, they cross with a wire, they use a small balloon to recover flow, and after that they decided to do a stent implantation with a 275 by 28 millimeter, and immediately you can see the problem. And it's even clear, more clear here now when you have angiography that there is a very big problem in this stent. So they tried to do some post-dilation at high pressure, but it really didn't work. As you can see, the stent remains severely underexpanded in this mid part. And this is a case from some years ago. At the time, really there were no many options to treat that, so the patient was left with this degree of underexpansion. This is something that can happen sometimes in primary PCI. It's a situation where we are not so careful probably with calcium, or we are not expecting so much calcium, and it's a high-risk situation to have something like this. And what happened with this patient? Well, he came back with a stent thrombosis. You can see that almost 1 year later, he came back with an inferior STEMI, very late thrombosis. And again, you can see that I was here trying to post-dilate this stent after opening the vessel. But again, this was not successful. And finally, you can see here in this OCT what is the cause. It's clear by angiography, but I think it's very, even more dramatic when you have a look with OCT. And I'm going to run it again for you so you can appreciate really the degree of severe underexpansion that the patient had. This is the normal size of the stent. And have a look here. I mean, the degree of underexpansion is amazing. You can see it here. Actually, it's 24% expansion. So really a very severe underexpansion that caused a thrombosis in this case. And actually, underexpansion has been identified as one of the causes of a stent thrombosis in all the registries. The Burn Registry, PEST, or Prestige, every stent thrombosis registry has identified underexpansion as a potential cause of thrombosis. Similarly, this is a case of in-stent restenosis. And again, you can see here that there is a restenosis in this obtuse marginal that, again, you will see in OCT is caused by the presence of a severe underexpansion. You are seeing it there, caused by the presence of calcium. And this was, again, the cause of stent failure in this patient. So clearly, underexpansion is a problem and is associated with clinical outcomes. This is a summary of multiple studies that have evaluated whether the minimum stent area had an influence in outcomes, thrombosis, restenosis, target lesion revascularization. You can see that in all these studies, this was actually associated with a worse prognosis for the patients. This is data from the Ultimate. You know, this is a study that compared angiographic versus IBUS guidance in PCI. And this is an analysis of the group that were treated with IBUS, comparing the patients that had an optimal PCI according to IBUS criteria and those who had a suboptimal PCI. Among the optimal PCI criteria, as you can see, one of them, and probably the most important, was the presence of a good expansion, defined as more than 5 millimeters square or expansion of more than 90% of the reference. Clearly, the patients that have a suboptimal stent expansion have had more events at follow-up. And this, again, more data reinforcing the same concept. This is a pooled analysis of Ultimate and IBUS XPL, again, two studies that compare angio versus IBUS guided PCI. In this case, this is the analysis of the IBUS guided patients. And you can see that, again, either using a cutoff of 5.5 or 5.0, the patients that did not achieve this minimum stent area had a worse prognosis at 3 years follow-up. So expansion is clearly related to outcomes. How can we measure expansion by intracoronary imaging? You can use absolute values, and you can see that the minimum stent area is actually the parameter that has been used more frequently, and actually the parameter that has more evidence in clinical studies to be associated with outcomes. But sometimes, of course, if you are in a vessel that is a small vessel or very proximal vessel, you need to use relative expansion indices. And this is the recommendation of the consensus document of EuroPCR. You can see that the idea is that you need to obtain a minimum stent area of more than 5.5 by IBUS, 4.5 by OCT, or at least your MSA should be more than 80% your average reference lumen. And which methods do we have to evaluate stent expansion? Well, you can see that the gold standard, of course, is intracoronary imaging, but there are other ways that we can use in the lab to try to evaluate whether the stent that we're implanting is expanding appropriately. We always use balloon expansion. We can see the balloon expansion in different views. This is something that we use frequently, or rotational angiography, to see if the stent is expanding in different views. And there's also the possibility of using stent enhancement. But of course, this is all limited to detect eccentric focal under expansion, because in the end, it's a 2D image. We need several projections or rotational angiography, as I mentioned. Sometimes also the balloon expansion is not really reliable, because once the balloon deflates, there might be some degree of recoil. And of course, all these methods are 2D images. They are not able to measure the minimum stent area. That, as I said, is the parameter that has been more related with events and probably the easier to assess in the middle of a case. So with this, I finish this short presentation. I think it's clear that the stent under expansion is a strong predictor of stent failure, and this is strong evidence in this topic. Angiography and X-ray device stent enhancement has the limitations for the detection of stent under expansion, and intracoronary imaging is the current gold standard, but of course is performed in a limited number of cases. So really the development of X-ray derived techniques for the detection of adequate stent expansion could have a high clinical impact. Thank you for your attention.
So, thank you very much, Nieves, for this background. Carlos, now we know how much is important and what could be used until now. Let's bridge in to a new reality and tell us a little bit more about this concept.
Thank you, Giulio. First of all, it's a pleasure for me to be here, and it's very exciting times because it's not every year that we have the chance to launch a new tool that will help us do a better job, and this is the case for this new technology. So my task today is to bridge what Nieves just showed, and these are my disclosures. And this is the problem. The problem is that if you are unaware of the plaque that you are treating and you implant the stent, as Nieves shown in her case, in a heavy calcific lesion, the minimal stent area will remain low, and we have seen how important that is in terms of outcomes. Nieves has also highlighted that the two main modalities today to assess stent expansion are IVUS and OCT. So this is the way that we have today to have a better and a quantitative evaluation of the minimal stent area. And you have seen also that there are different cutoffs. You can use method-specific cutoff, you can do relative index, but it doesn't matter how you define it, you have to assess stent expansion. Calcium is an important element in the prediction of the possibility of stent under expansion, and you see here that assessing the distribution of the calcium actually is able to predict not only towards where the stent will expand, but also the possibility of stent under expansion. You have seen the CT of this case. This is the angiography, and you will not be surprised that by treating this lesion that looks non-calcific in angiography, look what happened. You inflate the stent, you see the notch. The side branch is occluded in the meantime. You see no flow in the side branch. And why that happens is because the balloons that we use will not expand towards the calcium. They will expand towards the compliance part of the vessel. So you might see a beautiful opening of the balloon, but that doesn't mean that you're going to achieve a good stent expansion. This is something that we have really to understand because it's vessel biology in the response of the therapies that we apply. So when we look again at this case, I'll show you what are the methods that we traditionally use in the cath lab. This is the 2D stent enhancement, and you see here the clear notch of that calcium impeding the expansion of the stent, and this is the final angiography. So until today, angiography provides us with different tools that we're able to assess stent expansion, and this is available with all vendors. You see the names on the slide, and interestingly, the approach to validate this MSA derived from this 2D stent enhancement has been quite accurate in the sense that you see here in the x-axis MSA measured by IVUS, and in the vertical axis MSA derived from 2D stent enhancement. And I think that a correlation of 0.89, everybody will agree that is a quite nice correlation. Now, when we look at the impact, the clinical impact of the use of these technologies, of course, you will have more radiation, you have probably more fluoroscopic time, and this is one of the data that has been previously published, of course, in an observational fashion. Nevertheless, observational studies again, when you assess the outcomes of patients that have been treated using 2D stent enhancement, you see an improvement in the rate of target lesion revascularization, and this has led to a reduction in the rate of MACE. So addressing stent under expansion, even with this 2D angiography, 2D stent enhancement is associated with improvement in its outcomes. There's another study now showing you a 12% reduction in the risk of mortality recurrent MIO-TLR when you just put the foot on the pedal, get some stent enhancement, and correct the information that is provided to you by any of these machines. Now, the game has changed, and this is the new tool. It's called 3DStent, and it's based on a similar principle, but slightly different, in the sense that instead of doing one projection of stent enhancement, you need to do a rotational angiography, and this is what you are looking at, but actually, behind the screen, this is what is happening. You don't see this. This is a new technology called CMCT that is running behind the machine, and what is provided to you after all this computation is this. For the first time, a three-dimensional depiction of the stent during the procedure. And this is shown in front of you during the case. This is our experience, this is our cath lab in-house. And I just want to bring you this image because it really shows how easy it is to acquire. So you see here the machine, the C-arm rotating. I'm just doing exactly nothing. I just have my foot on the pedal, and I'm just waiting for this 20, that can be 10 seconds rotation to finish. And then after this, you'll have your three-dimensional images in front of you. And this is the final result. This is a drug-eluting stent, 2.5, 28. So you see it's a small diameter, and you see the level of visualization that you can obtain. And you can, of course, you are in the three-dimensional space, so you can rotate this up and down. You can remove the side wire. You can really go inside the vessel. Of course, we rely on intravascular imaging still. So in this case, you see the two side by side. This is the same stent that we control, of course, with OCT, and we apply the 3DStent technology. And you see here how these two images resemble each other in a way that was not feasible before. We have even taken a step further. Now we're quantifying the information, and then we're starting to understand that this technology is also able to provide us online, using angiography alone, measurements of minimal stent area, and you see the comparison with the measurements acquired from OCT. We're launching this technology today. There are many, many things that we still need to study. And one of the things that we need to highlight or to discuss is the limitations of this technology. And I think that it's important to understand that this allows quantification, but of course you cannot assess a stent at position. You will only look at the metal, which is very important, as Nieve mentioned, but we will not be able to look at stent at position. Radiation dose will be increased, and we have to recognize that. There's going to be several techniques or methods that you can use to reduce the exposition to radiation, but this is something that will happen. We'll have to, of course, to test this in a clinical trial to understand this better. And there is a limitation as well with patients that are obese. BMIs above 35, as angiography has a limitation with these patients. Also, this technology is limited to assess stent in very obese patients. And of course, we're launching this today. We're very excited. Nevertheless, we are in the process of an ongoing process of validating this with intravascular imaging as a reference. With that, thank you very much for your attention.
Don't move, Carlos. So, Dejan, Salvatore, you have the floor. It's the first time you are seeing this technology, and you have the chance to fight Carlos, and then start asking questions. What are the problems? And then we will give also to the audience for a short period of time, because the time is strictly limited, the voice for making a question. Dejan first.
Well, hearing what Nieves had to say, I think that the clinical impact of such a technology is undoubtable. So we are clearly speaking about something which can change our practice and impact the outcomes. Now, the question is, how can we turn it into reality and what the steps are going to be? And the first question that falls into my mind regarding this is, how is this technology different from what we already have? So this is a 3D reconstruction, and we already have availability of stent enhancement in a 2D mode. So, Carlos, since you've been using it, how do you see it?
So I think that the 2D approach is useful, but it's also limited in the sense that you will need to do the projection where the stent under expansion is visible. If you do the contralateral projection, it will appear expanded. So those tools are useful. To be honest with you, I use it systematically in all my cases, but you may miss things because you're not in the three-dimensional space. The second aspect is that the 2D technology does not allow for measurements of area, and this is a game changer. It's the first time that we can quantify MSA only with angiography, and this is for me one of the biggest steps forward.
So thanks, Carlos. Personally, I have to say that when I saw this image that now is there on the big screen, I was impressed, by the fact that we can get almost the same measurement between OCT and 3DStent. So that is something, that is impacting me very, very much. I saw in your presentation you talk about BMI that maybe is a limitation, so we may have some suboptimal results. So maybe I will ask you to comment a little bit more about what do you mean with these suboptimal findings.
Well, I think that we have done a few patients, and one of those patients was really a patient with a BMI above 35. And the quality of the image that you obtain is suboptimal for quantification. Okay? So I think this technology is very useful, but it has this limitation of BMI, which I think it's something that we also live with conventional angiography in various obese patients. So we have to be this is going to serve for a large population of PCI, but not for everybody, and we have to keep that in mind.
Given that...
Go ahead.
Just one single question more about radiation, since it's rotational angiography. So there are tips and tricks how you can reduce it for the operator at least, the dose of radiation, that you step away from it and so on. So how do you see it currently? So
there are two tricks for radiation reduction here. One is collimation. So you have to collimate the space that you want to acquire. You don't have to do the whole acquisition with the field open. And the second, which I'm still not used to it, Giulio, but I see in the cath lab next to me are the electrophysiologists, and they do a lot of these rotational things. And they go outside the room.
Yeah.
And they go outside the room, you see them all outside, say, oh, they are doing the rotational thing. And for us, these have never been the case. But perhaps this could be one of the strategies to reduce radiation for the operator.
Carlos, the most challenging is to listen to the voice of the audience. One burning question. Please stand up, come to the microphone. Go ahead.
My question is about, does it give information about the vessel? So if there are calcification, dissection, fibrotic lesion, etc.?
That's a very good question. And you know, when we started when we saw this technology from GE, we said, okay, it's good for expansion, but it's going to be even better for calcium. So calcium is one of the big potential of this technology because it will allow you to assess circumferentiality, arc, etc. Concerning the other composition of the tissue of the vessel, this technology is not able to distinguish any sort of lipidic or fibrotic plaque, nor the vessel wall.
I said one question, but there is one more. That is the last. Go to the microphone and say your question.
Right, so the comparison that you mentioned between the OCT and the 3D stent, at the best you said the 200 degrees rotation as opposed to the OCT, which would offer you a circumferential information. In addition to, with IVUS and OCT, you would have the vascular biology information, which you wouldn't have with this. And finally, since it's not validated yet, in your own center, in your experience, do you have any statistical agreement data between the two modalities? Thank you.
That's a very good question, and I think we have also to temper the enthusiasm in the sense that these are the first cases that were acquired weeks before the EuroPCR. And everybody was kind of looking at the first results. So the next step with this technology is to make a prospective validation and understand how this quantitative assessment of the MSA compared with intravascular imaging. And this is, of course, the logical next step.
Of course, the question addressed talking about morphology, this is not going to get to the morphology. But this is a new technology that needed to be proven in terms of reliability, but is something that can be very easy potentially to be used in the daily practice. Let's move on a little bit, and after Carlos, we are going to listen Hakim. Hakim had the largest experience in clinical cases by using this technology. Hakim, tell us a little bit more about this type of technology on the daily practice.
Thank you very much. I am very happy and proud to be here today to discuss. I'm sorry, where is the symposium? Okay, it is a very special story for me because I don't know how it doesn't work.
Just click on this.
Okay.
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 And then this one. And then, no, it's a... No, this is a different session. Can you go ahead?
I made a mistake.
So you needed to go, it's a different session. Okay,
This one.
This one, Benamer, Hakim.
Okay, I'm very happy and proud to be here today because this story began less than 10 years ago, and that's my slide of conflict of interest. And I'm a strong believer and a strong user of stent vis and stent enhancement. But when we have only a image with a 2D image, we can lose some information for the stent's expansions. So that's why I discussed with the engineers who are here of GE, and we tried to improve the process to have a tool to be sure that the stent was well expanded in every views. So let me show you some cases extracted from the first in man. We had 30 patients done in my institution. So the first one is a male, 80 years old, with no high BMI. Risk factors are hypercholesterolemia, current smoker, and diabetes. He came in our institution for an angina pectoris, and he had a previous MI. The ventricular function was low. He had no restenosis on the LAD, and I will show you now the circumflex, which was diseased with a tight stenosis of the circumflex regarding a small branch of the distal circumflex. So here you can clearly see the tight stenosis with a wire inside. We made a predilatation and put the stent inside this coronary artery, and then put a balloon with a non-compliant balloon at high atmosphere to improve the open of the stent. And you can see here the stent vis 2D, which was good, and we did a 3D visualization of the stent. As you can see, we can clearly see on the images the calcifications, and we clearly define the area where the stent is not very well opened at the middle part of this lesion. Here we can make a precise measurement of the diameters of the stent, and as we saw before, it is really impacting the prognosis of the patient when the stent is not very well open. Let me show you now a second case, which was a little bit more complex regarding the coronary lesion. It is a male, again, 71 years old with a known high BMI, a former smoker. He came on the institution after a myocardial infarction 1 month before. He was in Algeria. He had a thrombolysis, but no angiogram and no PCI, of course. No history of coronary artery disease before. He came with a good left ventricular function with only a small hypokinesia on the inferior wall. The coronary angiogram showed only a plaque on the LAD and a tight stenosis on the right coronary artery. So he was referred to do the angiogram and to perform the angioplasty. As you can see here on this view, the coronary artery was very diseased at the middle part of the right coronary artery with a calcified lesion and complex lesion. For this complex lesion, we did a rotablation because the balloon was very difficult to cross the lesion. So we prepared well the angioplasty. So the burr used was 1.5 millimeter. And we did predilatation, very important predilatation because the lesion was very calcified. And as you can see here, the result was good, but not enough, of course. We had to put stents. We put 3 stents on the right coronary artery. And those 3 stents were deployed and impacted with a non-compliant balloon at high atmosphere to be sure to have a good result. And then we had this result, this angiographic result. You can see here the stent vis done. We systematically do a stent vis, stent enhancement in all our angioplasty because it is very important to see that the stent is well open. And we did, of course, the rotational acquisition, as you can see here. It is very important to have a long balloon with the 2 repairs. That you have to keep in mind that always in the acquisition, the balloon must be on the screen. That is very important. And then the reconstruction shows clearly the stent and showed also, again the calcifications, and we can clearly see that this right coronary artery was really calcified. As you can see here, we can see also sagittal views of the coronary artery, and in different areas of the stent. and we can make measurements of the section. We did an OFDI for this patient, and the OFDI was really good. We have a very interesting images, and as you can see here, the measurement of the area of the section was really similar to OCT. We have to make a lot of studies again to be sure that the results are so amazing. So thank you very much to GE, because today we have the possibility to see our stent in the 3 dimension, and I'm completely sure that it will change our practice. Thank you very much.
So, thank you very much, Akim. Now, Nieves, she's using OCT, she's using IVUS every day. Nieves, try to interact with him about tips, about any type of question, practical question that you might have in your mind.
Yeah, so I have actually a question about the balloon.
Microphone.
I had a question actually about the balloon. So you said that you need a large balloon, a long balloon to do the acquisition. Can it be done with the same balloon of the stent, or do you need to?
No, yeah, it's a very good question. You only need the balloon with to cover the stent, the stent area and the stent and the area you want to study. So that's the only thing you have to do.
Okay, so for example, in a situation like this where you have a long segment that has been stented, you would evaluate it in parts.
Yeah, you can do
with
it.
The balloon, with the balloon in
yeah.
different parts, for example. This can be done.
But if you want to study all the area, you must put a long balloon, including all the stent that you have been put.
Salvatore.
Yeah, I have a very simple question, because you are the one so far with the most experience worldwide, I must say. And I know that you are very smart, because you are 99% radial operator. So what to do, for example, so if you have your patient with a radial puncture and you have to do this 3D, so rotation, that means that the X-ray is going over the patients?
That's a very good question. Usually, yeah, we use transradial access. So of course, the arm of the access must be at the same place, but the other one is at backside, and you have to check before doing the acquisition. You have to check that you will not touch the table and so on. So that's the most difficult, is only to be sure that you will not touch during the rotation of the tube.
Tejan.
Yeah, thank you. How about the wire? You showed all of these without the radiopaque part of the wire being inside the stent. Does that make any problems? Because there are some dedicated CTO wires that could be radiopaque all the way. Would that make a problem with the acquisition? Have you had any experience with that?
With the engineer, they told me let the wire inside, because it's another repair to make the reconstruction of the right corner of the stent.
Mm-hmm. I have another question, because we saw in the images that you can see the stent and also the calcium. Is there any way to isolate that and, for example, get an image only of the calcium?
As we said before, I'm absolutely convinced that it will be a very good tool to quantify the calcium and to adapt our tools to make a good preparation for the angioplasty.
Okay, Kim, thank you very much. Carlos, shall we move just gently to get some question? Can you come to this smart screen?
I will go to the smart screen, but I'm going to take the microphone on the podium.
Okay. Okay, here. Okay. Let's have a look to this first picture. So calcium, we were talking about calcium, and we said, well, calcium can be detected in multiple patients. Blooming. So normally sometimes when you're using some technology, you cannot be on focus because there is a blooming. What about this technology with the calcium? It's going to be obscure, we can see blooming?
So that's a very good point. And what you're showing here is a CT angiography where calcium is an issue. In CT, you get these blooming artifacts, and sometimes you get false positive stenosis because you cannot see the lumen. With this technology, and you have seen in the case shown by Hakeem, that you can really assess the calcium. And what I'm looking forward to start doing, Giulio, is assessing the arc of calcium using this method. So to answer your question, no problem in terms of blooming, super important potential application for detection of circumferential calcifications.
Okay, let's move on. And here you have one example. The one that was shown by Dr. Hakeem. Do you want to just to spend a little bit of time in describing why is the calcium and what we can get in terms of imaging?
Well, you see very clearly here, Giulio, you need to help me here. In the longitudinal view here, you see the calcification here.
You want to get to the microphone?
Which
Yes,
one?
just, okay.
You should have told me before. Good. You see the calcium here very clearly, and what is beautiful about this technology is that you can clearly see here the expansion of the stent at this level, but you see that here is clear underexpanded. And it's not only that the stent is underexpanded, but it's giving you the reason why. And you see here how this calcification is actually pushing the stent towards the lumen, and you can clearly see there we can draw there? Good.
Absolutely.
So you have here, you can see clearly the arc of calcium. In this particular case, after stent implantation, I think it's about 90 degrees. You see the other calcified structure here, and you see how the stent is actually being pushed towards the lumen. And this is what we see in intravascular imaging sometimes when we put a stent in calcified plaques.
Super. Keep your pen available. This was another concept you was mentioning before, how to limit the radiation. And you was talking about collimator. Any type of suggestion?
Collimation, I think that Hakeem also mentioned, you have to see the stent all the way. So the way that this works practically, at least in the first case we have done, is that we do a test run, only with fluoro, to be sure that the rotation, the position of the patient, everything is okay. And then we deploy the technology, the 3DStent, and then we acquire the angiography. So tips and tricks, collimate, that's very important. And keep in mind that, of course, the BMI plays a role. I think that's the two major points.
Okay, and no issue when you have multiple radiopack catheters?
So far, I have the experience to this is a case with a pacemaker. I don't know if with multiple catheters will be an artifact. The engineers are here. Perhaps that's a question for them.
Okay, keep in mind. Different platform. Can be used, different stents, tiny stent going down in terms of thickness. Is going to be a problem depending upon the alloy, the thickness, or not?
Not at all. All alloys are easily assessed with this technology, and you can also see the morphology of the stent. Let me tell you something. I have a Japanese fellow, and I show him the three-dimensional reconstruction, and he said, that's a science. Look at the connectors. So this technology is taking us to a place where we can identify even the type of stent just looking at the morphology and the connectors in the stent.
Super. BMI, we spoke before, obese patients. Which is the limit? You had the magic number of 35. This is something that we need also to collect, in my view, when we are saying that we needed to collect the clinical data, we needed to prove this technology means also for these patients.
Yeah, I think that the on label is 35. We need to understand how these behave. Of course, we're pretty sure that below 30, the images will look fantastic. We need to understand a little bit more between 30 and 35 to come with a number to say, okay, this technology performs in this way, and understand with the data in the hand, with the intravascular data at hand, what is the limit to consider using this technology in the cath lab.
Got it. Rhythm. Atrial fibrillation is going to make an issue in the acquisition?
Short answer, not a problem.
Okay, no problems with the atrial fibrillation. Potentials. Somebody said, well, we are going to use, Dejan was asking yesterday, pushing a lot, I said, cool down a little bit. So bifurcation, for instance.
I think that this is one of the niches where we see this technology providing a lot of benefit, understanding the morphology of the bifurcation, first in terms of calcification, location of the calcification relative to the side branch, then understanding after stent deployment, how was the stent actually expanded in the different parts, main proximal vessel, carina, etc. And of course, if you do two-stent technique, we have Dean on the panel, that you can even assess both branches in terms, of course, of extent expansion. And I think this is a big potential use of this technology. I don't know what are your thoughts, Dean, when you see this picture.
I mean, it looks very promising in terms that you understand what you have done, but it would also be nice to think about dynamically as you perform it, because there are issues from distal positioning of the wire through the struts that can be confirmed, and if that's not the case, you rewire once again, you perform the technology, and then you can confirm the position of the wire. That has always been a problem, because with intracorneal imaging, you need to do, for example, OCT run, and then you're not correct. You do a 3D reconstruction with OCT, you're not correct, then you have to pull out the OCT, rewire again. So these kind of technologies may allow us to more quickly get to the places we want with the wire. And then, of course, in some of the techniques, positioning of the stents need to be really meticulous. And with these kinds of possibilities, that I think could help us. Yeah.
So
but we'll
what
see,
was
of course,
wrong
that
is to watch to us. They are the R&D people around. Watch to them and say that we would like to evolve this technology
Definitely.
toward dynamic. So Carlos, I think that we cover with the limited experience that we have the potential, some limitations, some tricky suggestion, and there's still some clear space for interacting also with the audience. So you can just sit down a little bit. Let's go to get some discussion. Any burning question from the audience? Please stand up and go to the microphone.
Yes, in case if you have a two-stent technique, you just need one balloon and one main vessel. You don't need to put another balloon to assess the side branch stent.
Hakim, that is perhaps for you.
Yes, usually if you put only the balloon in the main branch, you will see the proximal part of the second stent and the bifurcation, of course, but you will not be able to see the reconstruction of the stent if the stent of the side branch is too long. You have to put another balloon inside the branch and then check the stent on the branch.
Any other burning question about the technology, please?
Do you see any potential application of this technology to peripheral stents, maybe femoral stents, carotid stents, or perhaps TAVI stents, maybe to analyze underexpanded TAVI in a bicuspid or...
Very clever idea, but okay, we are exploding in terms of potential, but of course it's something that we can thinking about. What about the length of the stent? There is Hakim and Carlos. There is in your mind any type of limitations? Is only, I would say, the single stent, multiple stent? Make some numbers for the audience.
So that's an important comment, Giulio, and I think that we need to know the technicalities of the tool. So what the tool creates behind is a cube of 5 centimeters by 5 centimeters. So everything that is longer than 5 centimeters will not fit in the cube. So that will be completely outside, will not be assessed. So if I may say, yeah, this is appropriate when the length is less than 50 millimeters.
So very reasonable answer. Hakim, your answer.
Yeah, you saw the right coronary artery. That was 3 stents. I absolutely agree with what he said. If the stents are less than 50 millimeters, it will be okay. Sorry.
Left main. Everybody is talking about left main, and we know that the distal left main is still a problem compared to the surgeons. And so this could be a potential application for this technology, Hakim.
Yes, of course. Regarding the left main, we need to have perfect results, and the impact of non-expanded stent is influencing the prognostic of the patient. So it is a very good tool to check if your stent is well open, and to check, especially when you stent the proximal part, the ostium, to be sure that there is no compression longitudinal compression of the stent. So there are a lot of application of this tool.
Okay.
I'm sure.
Giulio, I have a question for you.
For me?
For you. This is not in the script, I'm sorry. So you have been the pioneer of intravascular imaging and particularly OCT. You were telling me the other day the first experience in the 90s with OCT. And we have seen that despite evidence of use of imaging, the adoption is not as we wish it would be, in the sense that it's in the low numbers, it varies with the country. How do you see this technology applied in daily practice for PCI? How do you see the future with this at disposal?
Still working in a very active way in imaging to try to bring the concept of guidance of the PCI when you are dealing with a very complex disease. And that is what we are seeing on the table every day. And pushing the fact that is the baseline, the most informative, because you get all this data about calcium, morphology of the plaque, is soft, is hard, from where to go. So in fact, the concept of imaging today is moving from using only at the end of the procedure for assessing, but try to plan and mapping the procedure before. So I think that we are talking about technology that are going to be oriented a little bit in a different way. And I think that the most important is, anyway, we have a clear underuse of the assessment of the results because normally is limited to the angio. And we made the point on the Nieves presentation how much this limitation can be responsible for a suboptimal outcome. And I think that is my personal response. I wanted to give the voice to Dario, that is our chat master that is sitting mute until now, to give some question coming from a remote or from the audience.
Yeah. Okay, so the audience has been quite active, and the hottest question was related to the comparison with intravascular imaging. So if this should be a replacement of intracoronary imaging or not, but you already answered.
We say,
absolutely.
In my perspective, is not. Okay.
Then one very clever question, I think, is, okay, we perform the 3D stent, but it's when the stent is already deployed. So if we have an issue, the stent is already there. Do you see any perspective in the future about an assessment before the stent for the calcium and the calcium burden?
Carlos.
Yeah, I think that what we have in a plan actually is to take calcific lesions without any sort of preparation, put the balloon inside, run the 3D stent, and then do an OCT. And this is going to be the validation that we would like to do to understand what is the capacity of this technology, to look at arc, to look at thickness, and to look at length. These are the three elements. So I think it's too early to say that this tool is going to be fantastic to assess calcium, but the potential is huge, and we're certainly moving in that direction.
And then a final, very practical question, especially for those who have already tried the technology. You mentioned the systems to reduce the dose, but then on your perspective, what's the impact on the total dose for the patient? Have you seen like a doubling on the total dose? Is it going sky high or?
Akim.
No, absolutely not.
And also one number. In terms of a percentage, we can figure out of increase of dosage.
Average 5%, between 5 to 10 maximum, and no burnings on the skin because you are moving. So the incidence is moving, so no impact completely with on the patient.
Other question, Dario?
Just a fresh one about, what about stent edge dissection? Can you see it?
No. Stent edge dissection, another question for imaging expert. Can we see stent edge dissection, Salvatore? How we can see? Magically?
I don't think so.
Fancy.
No.
Okay. Salvatore say no, we cannot see edge dissection. We are not talking about a supplier of the intracoronary imaging. We are talking about the integration with the technology that we have.
And then a very last one, it's not strictly related to the technology, but still we are here to learn, so why not? Let's see that I detect a very elliptical expansion of the stent, but the area is good. Should I do anything, or do I leave it?
Okay, very quickly to everybody. Carlos.
I think when you have elliptical expansion, you should try to improve your MSA, but we need to acknowledge that even after the use of intravascular imaging in severe calcified vessels, expansion is not round and we don't get these beautiful results, and that is the way it is. Yes.
Anybody disagree? Nieves.
No, actually, eccentricity has not been related with events as long as you have enough good area of the stent. And actually, sometimes it's basically impossible. If you have a calcified nodule or a very centric thick calcification, it's impossible to get your stent round. You can actually get into very important problems if you try, and then you put the calcified nodule outside the vessel.
I absolutely agree with them.
Okay, nobody disagree?
No, I agree with the rest. Just a small comment that maybe you arrive late, because that is a problem maybe of the predilatation, of the preparation of the lesion, that you end up with an elliptic stent.
Yeah, if I can just link to that. So when you're doing kissing balloon inflations in left main or bifurcations, do not do a long overlap. That may cause these types of distortions. And just to link on the complementarity of intravascular imaging with this, some of the procedural planning, assessing of malposition, you could do with intravascular imaging, and you can use these kinds of techniques to supplement it and maybe not inject additional contrast dye to check your result and plan further.
Okay. And because, okay, last question, come on.
Okay, well, you said that the radiation is about 5% extra, but when you do it multiple times, it's going to be much more. But with the stent viz, the usual way we do it nowadays, we can do also angiography at the same time to save radiation. So we do angiography and we do stent viz on the same run. Can you do that with the 3D? So you can save radiation, you do angiography, rotational angiography, and stent viz at the same time.
To use this technology, you cannot inject contrast at the same time, so you have to do the rotation without the use of contrast.
Okay, and now you are seeing the video showing the navigation, means how we are going to use it. And perhaps, Carlos, you need to make a little bit of comments. So because we are seeing a different, I would say, the multi-planar view. You have a 3D in the upper side, and then you have a different, tell us a little bit, what does it mean, how you are scrolling, what is going to get?
So the thing is that by being in the three-dimensional space, you can actually rotate in any plane, Julio. You can even do a fly through in the stent if you want to do that. So these reconstructions are allowed to do that completely. One of the pending questions, now that you have this image on the screen, and I will tell you what it is, we did the first measurements in the core lab, and what we identified, we didn't know where to measure. So now we say we replace it on the top of the struts, behind the struts, inside the struts, and then we start saying, okay, we have so few cases that we still don't know. So one of the next exercise that we need to do as a community is to understand how to use the measurement tools that we have to better match an accurate stent expansion, which again should be by gold standard based on intravascular imaging.
Very clear. So there is a lot to be done. And so, for instance, below the 3D reconstruction, we have a couple of longitudinal view. Acting in practice means that you can move the axis, you can scroll up and down, and then change also all the measurements?
Yes, you can go cross-section by cross-section. The longitudinal resolution of this tool is 100 microns, so the same as a high-definition OCT pullback. So you can see really the cross-section next to the next one with a very, very high definition. And as you mentioned, from the longitudinal view, you can actually make these measurements. Giulio, I have to say that when I saw this technology, I was very excited. But the potential that this has to really inform us about stent expansion is huge. I envision that in the future, we will implant the stent, we will do the rotational angiography, and automatically we will get MSA in front of our eyes, automatic, during the real-time EuroPCR. And this is going to be something that will really facilitate our work in terms of achieving always an adequate stent expansion.
Okay, long way to go, collecting data, proving the essence. So we are arriving to the end of this session. Let's make a sum up of the key learnings. So we review the key role of a stent expansion for clinical outcome. Nieves, thank you very much for the state-of-the-art review. Then we discovered the 3D stents, like a new imaging tool complementary to the existing technologies, providing intraprocedural 3D and multi-slice imaging of the stents. We saw how the 3D is working in various lesion settings. Thank you very much, Akin, and thank you, Carlos, for your example. We highlighted the potentials, the limits, and the need of a further clinical validation. And finally, that is really the closure of the session. We hope you enjoy this time with us, and we wanted to invite all of you to visit the 3D stent session at the training village for the hands-on. And it's starting today in the afternoon. Thank you very much for attending this session.